So good morning, everybody, and I'd like to thank Uni for having me here. So OCTA is actually the stuff of a conference itself, standalone, and I think in Europe next month there's an entire full day conference on OCTA. So I'll try to roll it in 10 minutes. So, the three musketeers of AMD so far have been, the invasive fundus fluorescein angiography and ICG. OCT, of course, the redoubtable OCT held its own. And now the new kid on the block, of the fourth musketeer, is OCT angiography. So fundus fluorescein angiography has been the gold standard for diagnosing and classifying CNVMs. ICG has delineated the entire extent, and we seem to get a little more about the entire extent better, and also more importantly helps us distinguish AMD from PCV. OCT gives us structural imaging of the thickness, as we've talked about, intra and subretinal fluid, PEDs, and of course a qualitative and quantitative assessment. OCTA helps us look at those small neovascular sprouts which tend to be the early progenitors. It delineates it very well. Now, whereas conventional angiography, this is often concealed by late phase hyperfluorescence, and this hinders the precise characterization of the vascular features. Also, conventional dye-based angiographic fluorescein carries a risk of anaphylaxis. So OCTA provides a clear, depth-resolved, dye-less visualization of the retinal and choroidal microvasculature. Basic principle is motion contrast imaging, in one phrase. RPC movements of the erythrocytes are mapped over time by comparing sequential OCT B scans at co-registered point locations. Various algorithms are there. The most popular ones are the OMAG, or optical microangiography, patented developed by Ricky Wang for the Zeiss systems, and the SADA, or the split spectrum amplitude decorrelation angiography, used by many systems, most commonly the RTView. So benefits of any diagnostic are prediction and prognostication. So detection of neovascularization in AMD and PCV based on boundary-specific segmentation is required. Different segmentation strategies are used and based on the location of neovascularization. The ORC slab, the outer retina to choriocapillary slab, detects all macular neovascularization. Now CNV is now being called macular neovascularization. Outer retina to RPE slab detects type 2 neovascularization, and RPE to choriocapillary slab detects type 1 neovascularization and helps distinguish this from PCV, as we'll see a little later. So this is the RPE segmentation line, and this is the RPE fit, or the Brooks membrane. Now when you want to optimize this visualization for CNV or PCV and minimize projection artifact, one can either play around manually, or move it around, change the thickness of the RPE fit slab, or change the position of the RPE fit slab by moving it around. This particular article by Koskas very beautifully highlighted predictive features of OCTA for NV neovascular AMD. They looked at 126 AMD CNV eyes, 90 eyes of which had exudation. The study aimed to evaluate the predictive role of OCTA features in assessing CNVM status, and then develop a mathematical potential predictive scheme, which is what we're interested in. The structural OCT they used was a spectralis system. The OCTA was the swept source OCT on the TopCon Triton system. They used automated 30 micron segment slabs, which they moved manually from the RP to Brooks. All patients had the conventional fluorescein OCT imaging and OCT angiography, and all were on, obviously, anti-VEGF treatment. So 4 OCT angiographic morphological features were assessed: tiny branching vessels, vascular loops, peripheral anastomotic arcades, and choriocapillaris hypointense halos. The tiny branching vessels, which are thin tangle capillaries, we'll look at it in a minute, and the vascular loops, which are peripheral connections between these tiny branching vessels, were above 80%. Peripheral anastomotic arcades, which are inner anastomos between tiny vessels, and choriocapillaris hypointense halos, which is because of the choroidal low flow along these vessels, they were lesser. A summation of all 4 of these yielded the highest predictive value for exudative activity, about 98%. The most reliable 2 of these were, of course, the tiny branching vessels and the vascular loops, which had the highest correlation with treatment decision, as well as the highest relative risk for exudation. So these are the tiny branching vessels seen there, and the peripheral anastomotic arcades, the vascular loops within. So this is an example of this is slides courtesy my mentor, Dr. Phil Rosenfeld, who uses the Plexilite system. And this looks at a case with different components, and this shows beautifully the role of OCT angiography high level in detecting or delineating these components. So you have first the en-face OCT-A, then you have the en-face structure, which Uni has talked about, and then the OCT and this slab is showing the flow, the slabs used for this particular component and the structural OCT with the slab and flow subtraction. So just this OCT below. So you see first you have the type 1 MNV component, and then as the slab is moved up, you pick up the type 2 MNV component. So beautifully you see the different locations, and the composite, when you move, you have these two slabs included. Another example where you have a very separated type 2 MNV component and type 1 MNV component, and you see the entire component. You see how the lesion is, you can actually look at the different components in isolation. This is an example of a patient with a very high type 1 or occult CNV component. You can see the entire extent here, and with a small nest of the type 2 MNV component, or the classic component above that, and the entire component here. Another example of a patient who had predominantly regressed CNVM with a recurrence happening, and you see that on either side of the predominantly scarred CNVM here, which is hypo, you see the nasal type 1 MNV component, and when you move the slab above, you see the type 2 MNV component and the entire composite MNV component. OCTA finds a lot of utility in RAP, or the type 3 macular neovascularization, the classic RAP location with early phase and the late phase fluorescein angiography, the classic structural OCT with the PED, and the stage 3 RAP showing up, and you see the OCTA of the RAP as a world lesion right here and in magnification out here. This is an example. So looking at, it can also be used, as I mentioned, to prognostic or track changes. So this is an example of a 76-year-old lady who came with 636 vision. The pre-treatment picture, the fluorescein angiographic depiction of the RAP lesion, the classic OCTA of the, the structural OCT of the type 3, stage 3 RAP, and the OCT angiogram which shows the RAP lesion very beautifully. Post aflibercept, a couple of things. You can see the remarkable resolution on the structural OCT, as well as almost a complete clean out on the OCT angiogram. In RAP type 3 MNV, you find this, the cystic changes, kissing sign B scan with the flow, the color-coded retina, and you see the entire composite of the on-fast angio, the ORC slab which shows up the lesion there, and the tighter OR-RPE slab which shows the lesion also. But these have projection artifacts. Now you're going to see how when you clean up the projection artifacts, you find it so better defined. In PCV, this is where I think SSOT is going to have a big role to play. You have find the polyp, the double layer sign. You can see the ORC slab and the on-fast angio which shows beautifully with the projection artifact removal in place, the polyps and the BVN. And the tighter RP choriocapillaris slab which shows this. So this is almost, you can almost do away with ICG angiography if you have this in place. Again, another example with the color fundus photo, the fluorescein and the ICG angiogram which shows the polyps and the total retinal flow, and you see again with projection artifact removal, the polyps and the BVN showing up almost as well as you would expect to see with the ICG angiogram. So this is the marquee use, I think, of OCT angiograms, a beautiful publication which came out last year, probably the landmark publication last year from the Bascom Palmer group again, which looks at subclinical neovascularization in intermediate AMD cases, 110 intermediate AMD cases, 50 geographic atrophy cases. 23 out of these 160 had with incidence of 15, almost 14.4% of the subclinical CNVM. So 134 is completed follow-up, 13 showed the clinical CNVM, 10 out of 13, 77% had prior detected subclinical CNVM on swept source OCTA. So eyes with subclinical CNVM that went on to become clinical CNVM during the course of those 3 years of study, 21%. Eyes without subclinical CNVM which developed subclinical were only 3.6%, which is statistically a significant difference. No difference in cumulative incidence was seen between intermediate AMD or geographic atrophy, which means both can develop the subclinical CNVM. After detection of a subclinical CNVM, the risk of a clinical CNVM developing is 15.2 times that of eyes that do not have this picked up detected subclinical CNVM. So that's a major finding. So this is example. This is a subsource OCT showing the subclinical CNVM at baseline. The ORC slab you see here is there, and then 4 months later you see that becoming more intense, and then 14 months later you see how the subclinical CNVM is progressing. The patient is asymptomatic throughout. This is an example showing why this is important to look for. This is a subsource detects this and then shows conversion to a clinical CNVM, where you have this lesion here at baseline becoming a little larger, but still you see the structural OCT, there's hardly any change out there. But then just 2 months after this, you see suddenly a sort of popping up, and then you see that this has actually increased, and then a month later, you just finished in a couple of minutes, a minute or so, and you see in 1 minute, in a month's time, you see that this has become clinically significant, and this patient was treated with aflibercept. So limitations of OCT are large PEDs, subretinal macro hemorrhage, severe pigmentation, severe scarring of gliosis. There'll always be a challenge for them to move out. So with advances in OCTA, dye-based angiography may no longer be needed for neovascular AMD, probably in 3 to 5 years' time. It's predictive, it detects subclinical CNVM, as I said, in non-neovascular AMD, helps tailor the follow-up. You can, when you see that, you can decide when to call the patient if you're seeing it growing faster. It helps you strike earlier in subclinical CNV cases. It's an early predictor of exudative CNV activity, as we showed those features, tiny branching, vascular loops, etc. Distinguish, as I showed, between the different types of MNV, type 1 and type 2. Very importantly, helps characterize a look at type 3 or RAP. Early detection of a recurrent MNV network, as we saw an example. And very importantly, swept source OCT, I think, is going to have a great future in the imaging of neovascular AMD, especially in detecting type 1 MNV and distinguishing from PCV, where I think the role of invasive ICG angiography is going to reduce. Thank you.